Palliative care can be anything from very early on in a diagnosis when you know that you will not be able to treat or cure this patient. And so you already from the beginning have to make your therapy not inflict too much problems on the patient, but still help him or her as much as you can. And then at that stage, they're still doing very well. They can be very, very healthy and feeling well, but we know that in the end we will not be able to help them. And then it's a spectrum going over to the very, very end when you're almost dying, when you need another type of palliative care. But it's a continuum, I think, that you need to factor in, that sometimes it's not active at all, sometimes it's very active. It depends on the situation, it depends on the patient and what you can achieve to at that point, lift that individual's quality of life to a higher level. Sometimes you do very little, which is best for the patient. Sometimes you do a lot, which is in that case, best for that patient at that time.
Palliative care really means keeping the children as well as we can for as long as possible.
It's a very interesting word, palliative care, isn't it? I would like to change it and say that what we're providing is symptom care, because what we're saying is we want to make sure that children who we maybe cannot cure can live with their disease and be as comfortable as possible for as long as possible. In the modern age, we're going to have children who can't be cured, but who are still on treatment. There's a big subtlety about that. So what you're doing is you're using drugs and treatment to prolong the life of the child. And what you want to make sure is that the treatment that you're providing is not making them so ill that they cannot enjoy the life that they've got left. We all feel very bad if we have to say that we can't cure a disease. But we do want to make their quality of life for as long as they've got as good as possible. And sometimes we need other people to help us. When you have oncologists treating the children, they need the support of a palliative symptom care team to just say, we will take some of that responsibility off you. You don't need to feel that you've failed. You haven't failed, but the family need more support in a different way. And sometimes it's easier if different people provide that different kind of support.
If we come to a situation where it's difficult to know if a child will live or die, that's very tricky. That's very difficult to know, because we've all seen children who we thought would pass away and they didn't. The same as we've seen others who we thought would live and they did not. So you should be as flexible as possible for as long time as possible, and not commit yourself to one or the other roads too soon, because I think you can run into a lot of problems if you say to somebody, well, your son is going to die. And then it goes month after month after month, maybe year, and they want to know, how long can you be dying? Can you be dying for several years? Is this, we didn't think that it would be like this. So I think more flexible you are, the bigger the chances are that you will help the family in a correct way. So I don't think it's a set point where you need to do certain things.
Palliative care means different aspects of the life, possible life of a cancer patient in general, but any type of patient. So you may have palliative care dedicated to the treatment of the symptoms, acute symptoms linked to the cancer, that hopefully will be short-term, but you need to be sure that the patient, in that case, the acute patient, is not suffering too much for these acute symptoms that he might remember for several years later on. And then there is another palliative care for those unfortunate cases in which we tried everything, but we know that the chances of survival in general are very poor. And in that case, the palliative care is when, together with the family, we decide, okay, let's try to give the best quality of life, of the remaining part of the life, to this person. The oncologist sometimes has to step back, say, it's not anymore my business, because there are people that know better how to treat pain, how to maintain a good food intake, and so on, whatever it is the problem of the patient. I think the palliative care is becoming a specific part of the medicine. We need experts, because oncologists or whatever, even cardiologists or surgeons. We don't know all this stuff. We need experts that know how to use the best drugs to control the symptoms.
In the hospital where I work, we have different regions connected to us. We have about 1.8 million people in the region where we work, and we have in most of the local hospitals palliative care teams that now also take care of children. So it works reasonably well now, but it's still an issue on what can they do, how often can they do it, and it's not everyone who's comfortable to work with children who are very sick. Some of the patients and parents want to be in the hospital when they are really, really sick and might die. Some want to be at home as much as they can. Others want to be in the hospital when they need it. So I would say that it's not optimal where I work, but I think it's still, we're okay. We could probably be better, but I think we're okay. The palliative team in most of the centers that are around us, I would say, are based on the doctors and nurses. So you will have doctors with a special interest in pain relief, in other areas of palliation. You will have nurses dedicated to this. You will have social workers. I would think there are most of the time psychologists. You can involve others as teachers, physiotherapists, etc. Sometimes Sweden is a fairly non-religious country. We don't involve priests or religious individuals very often. But if it is a family that feel that they want a priest or an imam, fine, we will do what we can to assist them, of course.
The best way to give palliative care is with help and advice from doctors, but often the people who can deliver that care best are often nurses, or sometimes it might be a primary care doctor, a family doctor, closer to the home, but working together with specialists in the field so they give the children the best possible care. Psychologists and social workers, lots of other people, even teachers sometimes, can actually have a big role in helping the children to stay as normal as possible and to do normal things, and that's really important to the children and their families. In my centre, we're very lucky. We have a team of specialist nurses, and we've had that team for nearly 30 years. And they can deliver a lot of the care. They work with the family doctors and with many other people close to the patient's home. But they keep the consultants like myself involved so that we know what is happening and we can give advice and help when we are needed to. But the people who really look after the children are the nurses, the family doctors at home, and of course the families, the parents. Palliative care in general, but particularly palliative care in paediatrics, is a definite speciality. It's a multidisciplinary speciality, so lots of people are involved, lots of different types of doctors and specialist nurses. And it is not just something that one doctor can do on their own. It's not something that one doctor should try and do on their own. We all have different skills and different knowledge that can help, and you work together to get the best possible care for your patient.
I think palliative care is multidisciplinary. I think that's really, really important. For many palliative care teams, the people who are giving the care are very well trained, very well supported nurses, because that's their profession, caring. Doctors are very good at having a plan and seeing that plan through, but they're not necessarily so good in the day-to-day care of the patient. And so I think nurses are absolutely vital. We need doctors because doctors will bring in all the drugs that will help the symptom relief and will monitor the ones that are having chemotherapy to prolong their life. So I think we need doctors, we need nurses, we need psychologists. Now the psychologists are not just supporting the families, they're also supporting the staff. It's very, very hard for staff day in, day out to be treating children who potentially are going to die and do die when they're caring for them. So they need support, but also the families obviously need support. And social workers are important because it's an enormous financial burden to the families. The husband may have to give up work for a while, the wife might have to give up work for a while, so there's no money coming in, and yet you're having to go to hospital appointments, you're having to do all these things, and you want to give your child all the opportunities that they can have while they've got time to live. So everything is very expensive. So social workers are very good at helping them and giving them a package and supporting them and saying, yes, this is the right thing to do, this is what you should do, this is where we can help you. You must have a team to do it. The doctor needs as much support as the family needs too. So you need a whole team, and different people approach things in different ways. And some families might find that a nurse is the person who gives the most support. Other families might feel that they need a doctor giving the support. Other families might need the psychologist giving support. So different families require different methods of support, and I think we need to be very aware of that. I think it's very hard for one person to run a palliative care. Well, they're not running a palliative care team, are they? They're just running palliative care full stop. I worked at Great Ormond Street Hospital, which is a big paediatric hospital in London, and we were very lucky. We had a palliative care team who served the whole hospital. Cancer is not the only disease where children die. So that they supported the renal team, they supported the neurology team where patients have terminal illness, life-shortening conditions. And so palliative care supports intensive care, a child who's come in with an accident who may not survive. So palliative care it's a very broad thing, and I think actually oncology probably led the way to setting up palliative care teams within hospitals, because I think we recognised it very early. Because believe it or not, when I first started doing paediatric oncologist, our survival rate was 30%. It's now 80%. So we were faced day in, day out with not managing to cure patients. And when we eventually were allowed a palliative care team, it relieved us enormously. I mean, the weight on people's shoulders of having to perpetually say, well, I'm sorry, we failed, is pretty hard, actually. So I think that's where the palliative care team came in, and it was wonderful. It made such a difference to our working life. When I started this interview, I talked about symptom care management rather than palliative care management. And I think if you phrase it that way, you could bring it in much earlier to the families. It's much more acceptable to the families if you say, actually, I'm going to manage your child's symptoms rather than I'm going to manage your child's death. There's a big difference. And I think you need to bring the palliative care team as early as you possibly can. I think a lot of bereavement counselling is provided to the family members. And it can be extended to school friends of the children. It can be definitely extended to siblings, grandparents, whoever needs some kind of bereavement. And also, it's to put it all in perspective, to say, it's normal to cry every day. It's normal to think about your child every day. It's normal to be sad. Because some people feel, oh, my child's died, it's 6 months later and I'm still crying every time I go out or I do something familiar which brings back the memory. And it's to normalise bereavement and to say, you're allowed to do that. That's the way it is. And different people bereave in different ways. And men bereave in a different way to women. So sometimes families break up during the bereavement period because they can't see that different people bereave in a different way. And palliative care teams can help that.
Well, it depends on what you mean with palliative care. If palliative care is connected to a child that will die, that's a different matter. But palliation means to alleviate and make suffering less. So you can say that in that sense we palliate all our children, that we do what we can to make that they're not suffering. But if we leave it to the area when we know that unfortunately that child will die, it should start as soon as you feel that this is an issue. And like I said, that can be almost a diagnosis for some diseases. And then it's later on for others where you have a relapse or a refractory disease which is not responding to therapy. And then you have to sort of decide that now we've tried what is reasonable. And for the sake of the child, it's not reasonable to do more because we will do more harm than good. So then palliation comes in, but then palliative care can, as I said, be extremely active at times and then less active at other times. It's what is best for the child at that given point is what should dictate how active palliative care is.
I think really it depends a bit on what you mean by palliative care. But if I look at what I think of palliative care as being, it's when you know that you are not going to be able to cure that child in the end. That might be many years before, sadly, they die from their disease. But at that stage, you start thinking about what is really important for this child and for the family. And what's really important, yes, it does involve keeping them alive for a long time, but alive with a good quality of life. And quality of life and helping them to do the things that they want to do, and helping the families to do the things they want to do, and helping the child to feel as well as possible, hopefully with no symptoms. That is what is most important, and that's even more important than how long they survive.